is, a refresher, so you already had this, you already know this kind of thing, is kind of to bring things back to the front of your head. So this is gonna be more driven by you than me. So this is neurology. Tell me a neurologic problem that we might encounter.
Alzheimer's.
Okay, Alzheimer's. What is that? It's what?
You forget things.
Yeah, it's even worse. You forget even at the end to feed yourself. I mean, they'll eventually deteriorate into you can't take care of yourself. Alzheimer's is diagnosed by on postmortem, because you got to look at the brain. So a lot of things can cause not remembering things, like me. I don't remember things. Tim, you ever forget things?
All the time.
I don't know why I have passwords. It only keeps me out. So that's a big diagnosis. Can it be treated?
Well, the symptoms can be mitigated.
You can try to mitigate the symptoms. You can trying to find ways to slow the progress. So what's a broader term for Alzheimer's?
Neurodegenerative.
It's a neurodegenerative disease. Do you have dementia or do you have delirium? What's the difference between those two words? Delirium, dementia.
Which is a neurologic disorder.
Well, they're all neurologic disorders. Alzheimer's is dementia, a form of dementia. There's Lewy body dementia, which Bruce Willis has, that Robin Williams had. It's a particular thing, but you usually have to be able to look at the brain itself. But dementia is not going to get better. We can't fix it. We can't make it better. It's progressive, and it's terminal. What's delirium then? I'm trying to get you to talk. If dementia is terminal, then what do you think delirium might be?
Acute.
It's acute?
It's accompanied by some other comorbidity.
Something causes it, but something causes everything basically, even if it's age related. So one of them's not gonna get better. Can we make the other one better?
Yes.
Which one can we make better? Delirium. So delirium is acute onset. And if we can figure out what's causing it, it can be fixable. So we go to somebody's house and they're confused. Okay?
That doesn't really.
That's pretty broad. So we go to Salem Health and Rehab, and the patient's confused. What do we want to know about that confusion?
Everything. Past medication.
Yeah, but that's still pretty broad. You ever seen that
Is
med
it?
list?
Okay, sorry. Is it normal?
Is it normal for that person? If that's how they are, that's their normal, that's not delirium. That's dementia. That's where their brain function has deteriorated too. But if we go there and they say, the nurse says, or the aide says, because you can't find a nurse, they're confused today. Were they confused yesterday? No. Yesterday, the patient knew my name and knew which room was their room. Today, they don't know my name and they're wandering into other patients' rooms. Does the patient have dementia or delirium? Something that acutely recently has happened to change their mental status. They may have some degree of dementia, but something has happened acutely to make it worse and has made them have delirium. So what can cause, since we can't fix dementia, Alzheimer's, Lewy body dementia, a host of other ones, what do we want to know about delirium? Something we might be able to fix. So you go in, the patient is confused, this is an acute onset, they weren't confused yesterday. How do we want to assess them?
Continue with medical assessment and vitals. Take background.
More specific.
Oh, what did they do today that they didn't do yesterday?
Okay, yesterday, they knew my name, I'm the aide, because you can't find the nurse, and they're wandering into other patients' rooms because they don't know where to go.
What's causing that? I don't know.
So, that's why you're there, why?
Yeah.
What's causing this? What are you gonna ask the patient? What are you gonna ask confused Dee Dee, who's wandering into other patients' rooms because she can't find her room?
Does she know who I am? Does she know her name?
Well, I'm gonna stay on the rescue squad, she ain't gonna know me.
Oh, does she know the date, where she's at?
Okay, you live in a nursing home, days don't matter. They're all the same. Hell, I don't know what day it is most of the time. I worked from Wednesday to Tuesday. Do you think I knew what day it was?
You work backwards from Wednesday to Tuesday?
Yeah, no, I worked forward from Wednesday to Tuesday. So I never knew what day it was. My Saturday started on a Wednesday. My Monday was a Tuesday.
I don't know what to ask them that's gonna give me a different answer.
Yeah.
I seriously don't. Because if they're already.
What's the first thing you ask somebody when you meet them?
Hi, what's your name?
So what's your name?
So you ask your patient what their name is. That's part of the GCS. Okay, so ask her what her name is.
Sam, what's your name? You know your name?
Don't ask her like that.
That's kind of accusatory.
You don't know your
Hi,
name?
Sandra.
Okay, nice to meet you, Sandra. What's going on today?
introduce yourself. Hi, I'm Jason. What's your name? Make it very normal, like conversational. Not an interrogation, but you want to get information out of it.
I will. Hi, I'm Jacob with the rescue squad. Do you know your name?
Well, yes, honey, my name's Sandy.
Nice to meet you, Sandy. Do you know where you are?
Where am I?
It's a good question. It's a great question.
Or where do you live? They might say, I live here.
This is my house.
Where's here? Can you tell me the address? And if they give you some other address other than 1945 Roanoke Boulevard, they're probably giving you
Their old home.
their home address.
It's 201 South 5th Street.
Yeah, I bet it is.
So is she oriented to place?
No.
Not if she's at the sharp. How old are you?
I'm 48. I'm 48, honey.
Okay.
Yeah, you look at her chart and it says she's 75. How are we doing with time?
Back a couple years.
So we're not oriented to time. We're not oriented to place, but we're oriented to person. Person's usually the last thing to go. You can get Alzheimer's patients that don't know who they are. It can get that bad. So, and then I would ask the age. So, what's different about her today? Well, she's wandering around, going in the other people's rooms. She can't find her room. And she doesn't know my name. I've worked with her all week. Alright, so we're doing our GCS. There are 3 components to GCS. So we just did one component. We did the orientation part. Another part's eyes. That's easy because we look at everybody. Most of our patients have their eyes open. So we'll give her 4 points for that. And on the orientation, she failed that, right?
But her words are
So,
coherent.
but she's talking. She gave me an answer to the question of where she lives, but it was not correct. Okay? So that would be, well, just do the verbal part. We'll give her 4 for the eyes. Is she oriented? We start at 5. She oriented? She thinks she lives at 201 Broad Street.
No,
Oh, yeah,
And
no.
she thinks she's 48 years old.
no.
Okay, so she answered the question, but she's confused as to the answers. So like you on tests, right? Well, it had something to do with the heart, so I said heart attack. So we'll give her a 4 for that. Speech is clear, the words are appropriate to the question, but not correct. So we'll give her a 4 and 4. And the next one is motor. Alright, and she's up walking around, not going to the right places, but she's up walking around. You know, and when you introduced yourself, you reached out and you took her hand. You know, you can shake it, and now I'm also, what am I doing? I'm feeling her skin. It's warm, it's dry,
It's pink.
she's pink.
So she gets a perfect score.
She gets a 6 for that. So she's 14. So she's a little confused, but not bad. But something's different today. What can cause altered LOC? We have a whole protocol for that. The things that can cause altered LOC are
Strokes.
lots of things. So in the protocol, get my good side. Who's looked at their altered LOC protocol? Everybody should have looked at their altered LOC protocol. Alright, let me see if I can
Okay.
pull it up.
Cause of confusion in nursing home patients.
UTIs.
Good job.
hypoxias,
Yes.
low blood
So what are you gonna check on all your altered LOC patients? Every one, regardless of
GCS.
your good GCS, and you wanna check what?
We just talked about it with,
blood
Tim.
glucose levels.
good job.
Right, you're gonna check glucose.
First thing I thought.
I don't want Washington. There we go.
And a big one that's been in the media is like alcohol withdrawal, substance abuse withdrawal. is another reason.
Carbon dioxide, or carbon monoxide.
Yeah.
Download. Okay. That is not what I wanted. But that's a good thing to have. I love it when they put forms out there and they don't tell us to change stuff.
Oh, yeah, yeah, I've had it happen too,
It's something we need to know,
yeah.
you and me. This is what I wanted. Okay, bring up our protocols.
Miss Dani, I gave you one, just so you have. I figured you'd want one.
Yeah, I was a student. So, later on, sign that one.
Yeah, okay.
Yeah, I don't need all 34 results. Three, 22,
And I'll
21,
scan
22,
anything in this evening for everybody.
19.
So, Mackenzie, I'll be scanning your Con Ed this evening.
Alright, that's fine.
And you definitely need to bookmark this.
So while Jane's looking up the things that she needs to get to, so just remember that when you go into any call where a patient is acting differently or, they have an altered mental status, you're gonna need to key in on what's different, what's related to this patient. Why are they going through this? Is it because they've become acutely ill? Is it because they're withdrawing from something? Is it that they have, some kind of neurologic condition going on? Have they fallen? And what are they doing that's different? You know, you wanna find out why you were called. Why were you called to the scene? And what's different about the patient as to why you're there? Because if the patient's not acting differently, why are you there? And those are where those little boxes on your image trend, it's normal for patient. That's the difference between what's normal and what's normal for a patient.
So when we do go in scenarios like, this is not normal for them, but their normal is also still not normal, instead of just doing blood glucose and O2, which also not what's relevant as well.
So you need to know what patient's normal is,
Yeah.
what their baseline is, okay? Y'all have met Mike Moore, right? If you never met him before, and you started talking to him, what would you notice first? His speech, right? Well, that's his new normal. But if he was speaking clearly yesterday, and he's speaking as he speaks now, that would be a problem. So I've had to ask families, is this normal for them? They always talk this, oh yes, they had a stroke, 3 years ago. Do they seem okay to you? No, they're definitely different today. Alright, so we have a confused or unresponsive patient, but they're breathing, so we're gonna not go to that protocol. What does this box here mean? Oh, look, I get my pointer. Confused patients signing refusals is a problem. So what's the first thing we're gonna do? We've established that this patient is confused. What's the first thing on the list there? We're gonna check their glucose. So it's right there, glucometer. Why is that at the top of the list?
Because if the patient has a really low blood sugar or really high.
If it's low,
Or high, it's.
high, less so, but also we can't fix high. But a low blood sugar can make people confused. Okay? Can we fix low blood sugar? So we can fix their confusion. Yay, we wanna find this out right away. We don't wanna wait until they've been in the hospital for a day that, oh, their blood sugar was low. We could've fixed that yesterday. Alright, so in our region, we do 12 leads. E stands for EMT, okay? So, you get a 12 lead on. Okay, A stands for EMT advanced, so we don't stick a saline lock in them. And look, the protocol, which you should have burned into your mind, gives you a breakdown of all the different reasons somebody can be confused. So, diabetic, abnormal glucose. Okay, it's not that. Are they homicidal, suicidal, seeing things? When you're talking to Sandra over there, you know, she starts talking to somebody in the corner. And you go, who are you talking to? Oh, I'm talking to that man over in the corner. He's been following me. Alright, now we got a whole nother bailiwick of problems here. She's seeing and possibly hearing things that the rest of us don't. We call that hallucinations. That makes us think we got a psychiatric problem. She might already have a psychiatric problem. And she's having a breakthrough. Overdose or toxicity. Well, she's living in a nursing home. She probably did not, although she could, because they wander off all the time and go down to that little gas station there on the corner and buy liquor, or buy beer. But it's not likely that it's that, but could she still have exposure to medications in a nursing home? I mean, that's kind of what they do there. They dope them up. Everybody over there, you look at their med list, they're always on something for anxiety or, what do they call it? Mood stabilizers. You need to put me on a mood stabilizer if I was locked in the shark. Cause I'm not gonna be a happy person.
You need to put me on one when I just go in there.
What?
So I just need to be on one when I go in there.
No, I don't wanna know what's going on. But they're also older, right? So their liver and their kidneys, their whole metabolism doesn't work as fast as ours does. Mine's already slowed down. That's why I've got this little spare tire around me. You know, I can't eat like I used to because my metabolism is slowed down and now I store fat instead of burning it off. When I get even older, I'll have, you know, a 70-year-old liver and I'll have a 70-year-old set of kidneys They don't work as well. I don't clear the medications that they're giving me as quickly as I used to. So, in a sense, yes, I am an overdose toxicity patient, or could be. So the med list on the elderly at the Shark is very important to have, because they have polypharmacy. What's that?
I remember one time we had a call at Mount Regis. Would tox also be related to like detox as well?
They could be going through withdrawal. Yeah,
Would that
alcohol withdrawal.
Okay.
You can die from alcohol withdrawal. Keep that in mind when we go down to 700 Delaware Street. If he's ever sober, we got problems. So you can die from alcohol withdrawal, which causes confusion, hallucinations, agitation, restlessness, fever. That's DTs. You can also die from benzodiazepine withdrawal, if that happened to be your drug of choice. You don't die from narcotic withdrawal. You don't like it, you throw up, you're agitated, you got a boatload of pain all of a sudden, but you're not gonna die. But those benzos and alcohol will kill you, withdrawals. And they'll also kill you if you take too much of them. Did the patient have a seizure? Well, probably not. I mean, if she was still laying on the floor and confused, I might think seizure. But if she's up walking around but confused and doesn't know staff member, less likely seizure. I mean, she could have a petit mal seizure, which is the one little part, but that's not high on my list. Is she sick? She could have a fever, she could have a UTI. We're at the Shark. UTIs cause confusion in elderly all the time. They don't necessarily have to have burning and peeing all the time, like having a UTI does, but they get sick. So that's why we got sepsis down there, to remind you to go to the sepsis protocol, which is a critical care protocol. Did she have a head injury? These people fall all the time. And it may not, maybe she didn't fall today or yesterday, maybe she fell last week. And she's got this slow growing subdural hematoma. Because they can be acute, I just wrecked my car, I have a hematoma. Or they can be chronic, I fell last week or 2 weeks ago, or multiple times, and it's slowly accumulating. So it could be head injury. Have you had any recent falls? Has she had any recent falls? I have to ask the aide. Oh, she fell last week, but she did okay. Oh, but she's also on a blood thinner. Oh. Med list, very important. Did she have a stroke? Well, that's kind of what we're talking about here. She could have, and then we'll do the, we did the 12 lead, so it's not too fast, not too slow, blood pressure's okay. So we kind of rule out the cardiac stuff. So now we're gonna look at the stroke. Is she at risk for a stroke? She's older. She have high blood pressure? Probably. So now we do the stroke scale. Do a stroke scale on old Sandy here.
Hey Sandy, could you smile for me? Give me a big smile. Okay.
What are you looking for there?
I'm looking for facial droop on her, and I'm not seeing any in her smile.
Okay, and she followed commands.
Yeah. All right. Now can you hold your arms out like this, and then close your eyes? Push your palms up.
There you go.
Cool. Oh, no, not cool. All right. You're good.
Nope, she's not good.
Oh, I know.
What was she doing?
Oh, no, yeah, I know.
Do it again.
No, she was doing this.
Okay, she's got
Yeah.
it.
I was telling her to stop. Yeah, so that's not good.
So what does that tell you?
Instability.
Alright, the reason you have her close her eyes when they're doing this is if they're looking, they will automatically, without thinking about it, keep the other one up. But if they close their eyes and there's weakness and they don't see it, it drifts off. Occasionally, in a certain, I can't think of the reason, sometimes they'll drift up, but usually they'll drift down, it's weak. It's like you're trying to hold up a heavy box, and you just get weaker and weaker the longer you try to hold it up. So they're holding this box, and this side's weak. So, which side was weak on her?
Right.
Right side, okay? And what's the other component of the stroke evaluation?
Speech.
You've been talking to her,
Yeah.
so you've already actually done it without thinking about doing it.
Oh, yeah. Can you say the sentence after me? I can't teach an old dog new tricks, or.
Can't teach new dog old tricks.
Oh, that's me. Oh, alright. No, she didn't pass that part.
Okay.
Little slur there.
Little slurring, and she got it back afterwards.
And then the CNA said that she was normal yesterday, so
Mhm.
that would be the time.
So, there are a couple of different stroke scales, but they're all pretty much the same, but everybody likes to have their name out there. So the first one was the Cincinnati stroke scale. And we were supposed to ask them, the skies are blue in Cincinnati, that was the word. It doesn't matter what the phrase is. You can have them do Mary Had a Little Lamb. What you wanna know is, can they repeat it back, hearing, they can speak and it's not slurred, and they get the words right. She didn't get the words right and she was slurred. So we have facial droop, arm drift, speech, it could be slurred or confused. Fast, doesn't spell anything. What's the T?
Last normal.
Time, last, normal for them. What's significant about this?
How long has the suspected stroke been going on? Are we still within that window?
Right. It spells the word fast, we wanna act fast. Some event happened to the patient medically, we try to nail down what time that happened, when this change occurred. So when was the last time normal? What's the window of opportunity to treat a stroke?
An hour?
Hmm?
An hour, half an hour?
3 to 4, RMH is doing some experiments with 6. Depends on the intervention, but the longer it is, the worse the outcome. Less reversible. RMH is a comprehensive stroke center, Blue Scale is not. RMH can send you to interventional radiology, they can thread a catheter up, they can suck the clot out of the vessel, or they can inject TPA, a blood clot buster, into that vessel. So that spells fast, yay. And then there's also be fast. Because when we're doing assessing this stuff, it doesn't show up very well, I'm sorry. You wanna read that? This is called a homunculus. And it's funny looking, but what it is the brain, alright? It's a slice of the brain, front to back. I just cut out a slice like I'm cutting pound cake. So this is the motor section of the brain, a little segment. And the size of the image indicates the number of neurons dedicated to that body part. So the tongue and the lips are bigger because they're very sensitive, right? The eye is not the function of the eye, it's not your vision in this section of the brain, that's the occipital part, but this is it's sensation. If I poke my finger in your eye. The hand is really big because we have a lot of nerves there, less so around here. And kind of geographically, this is how it's laid out in the brain, so that's why when we have arm drift, we're talking about this part of the brain up here being affected. And we have them smile and speak, we're assessing this part of the brain. Okay? Does it make sense? That's why we're doing this. The legs are all the way over here, and that's the motor part. But in the B-fast, balance, what part of the brain takes care of balance? It's a different part of the brain.
The medulla oblongata.
No, that's our brain stem stuff. It's that little.
Hippocampus.
No, this little part back here, the cerebellum. So a little, they often describe it as worm-like. Is my pocket, there's my pocket brain, my spare brain. Couldn't remember where it was.
I left your brain over there the other day.
I know.
I leave my brain everywhere too.
So this image is like a slice taken right about right here. We have a motor and we have a sensory section. The balance part is the cerebellum, and that's this green part down here at the bottom. That's our balance. That's why, and I mean, they're all interconnected. That's why I can stand on one foot, raise my arm, put my other arm here, and I'm moving my leg. So it's still part of the program. This part is my leg moving to keep my balance, right? But what's telling my leg to do that? It's this. If my cerebellum's not working, I can't do this. That's part of what tells my body where I am in space. If I put my arm behind my back, I still know I'm holding up 2 fingers. I can't see them. Oh, that's 3 fingers. How do I know that? Cryoperception. So, this is my little cerebellum. So if I have a stroke, most strokes will be along in this part of the brain. Occasionally, you'll have a cerebellar stroke. It affects the cerebellum. And these are the people that they're staggering all over the place because the brain can't keep them balanced anymore. So the B-fast is balance. This one is the eyes. Unequal pupils, eyes that deviate to one side or the other. And they'll still talk to you, but their eyeballs are over here. And they can't bring them across the midline. Or maybe just one eyeball goes off to the side. If that happens, they will have double vision because they're getting 2 different pieces of information. So this was Cincinnati, and then we had FAST, and now we have B-FAST, because it's kind of a marketing thing, B-FAST, to respond to these symptoms because of that short window of opportunity we have at the hospital to treat them and try to correct this. But these three tests right here, facial droop, arm droop, and speech, take up a big section of the brain, and that's what we're assessing. And then we throw in balance and pupils, eyeballs, now we're doing a little brain stem, we're doing the cerebellum, we're doing the cerebrum. So if she was weak on her right side, where do you think the stroke was? It's on the left side. Because I don't know for what reason we were cross our wires. I've never had a good evolutionary explanation of why we do that. Okay, so we're at the shark, we got our med list. What else do we wanna ask them for at the shark? We're getting ready to transport them.
That's it.
We wanna know if they're DNR or not. What's their advance directive? They have a post form, because that information is important to the hospital. I tend to forget to ask at the house, I assume they're, not ready to kick the bucket. But I always ask at facilities, because I don't think you should be in one without a DNR. Any questions on that? So these are all potential reasons for an altered LOC.
Jane, this question pertains specifically to like nursing homes, but since they are under care of the shark,
Uh-huh.
can they refuse transport? Like if their mental status is not altered, can they still refuse transport?
Yes. They're not gonna like it at the shark. Some people there don't have capacity, and some people do. Some people are there because they're there for rehab, usually 30 days, because they had a hip or knee replacement, and they're supposed to get physical therapy twice a day, so they can get strong enough to go home. The last one I picked up, she'd been there 2 years, and her mental function was fine. She's 55 years old, which is very sad, but she was non-ambulatory. I think she'd had a hip replacement, maybe? And I'm not sure why she did not successfully get out of there. But she wouldn't give me a hard time about going. She kind of knew what she was up against. Oh, you got a UTI, you run, She gave me good history, better history than what the chart did. I mean, the chart had the meds and some allergies and stuff in the, I'm looking at the bag, and she had an IV going. And she told me actually probably the most important thing that she couldn't have, because she's nauseated. She said she hadn't eaten in like 6 days because she was nauseated. And she goes, I have long QT syndrome. Okay. She doesn't have that listed as an allergy, because it's really not an allergy, it's a cardiac problem. Remember, we did an EKG on our patient, right? Alright. I'm lost. It was page 36, I think. Okay. I didn't do a 12-lead on her, but but she told me she has this underlying condition, a cardiac condition, where she has a long QT, which is a longer space between her little squiggle lines. Yeah, they gave me Zofran and I went into cardiac arrest. Patient's telling me this, not the staff. Okay, and she's nauseated. What medicine do we have for nausea? Zofran. First thing I told the nurse when I went in, it's not in her chart, but she has low QT, so don't give her Zofran. The patient goes, no, I don't wanna go through that again. I'm like, shit. You're more on the ball than the staff was. So, we have a protocol. If you get lost, you should have this on your phone. Do you have it on your phone? Okay. It should be, I don't know if we've updated it, on the laptop, the protocols. Might be something we could check. Okay, so, any more questions about stroke? Can be cerebellar, they're tricky. Because you'll think they're drunk because they can't walk a straight line.
Can they talk good?
They talk. Cause it's the balance part back here. I had a cerebellar stroke down at the, Hardee's on West Main. He drove there. He went in, barely. I think he got into the store, but when I saw him, he was outside the store. The store called because they thought he was drunk. And we get there, and the engine thought he was drunk too, but he didn't smell drunk. And so, where do you live? Well, I live in Appomattox. Well, that's over an hour away. What are you doing here? I don't know. And I'm thinking, if I was drinking, would I drive from Appomattox? Could I drive from Appomattox drunk and make it to West Main Street? Probably not. So, and her blood sugar was okay. So I took him in. I didn't want him to go to jail. And he had a cerebellar stroke, young guy too. And he was sort of confused because, he didn't know why he would have come to Salem, or why he was there. And I don't know why he stopped at Hardee's. But he was a young guy, maybe early 40s or something, and he had a cerebellar stroke. Because the blood supply to the cerebellum comes up the back through the vertebrals, so you can injure those neck injuries, you can plaque them, you can get plaque, they're not very big. I'm not sure why he had that stroke. And I took him to Louisville. It was an interesting conversation because they just moved down here from New York and the wife had no idea where Salem was. I'm gonna run down and get the power cord, because we're about dead.